Yes. Started recording. Great. Good afternoon, good morning, and good evening, everyone. Welcome back to week 6 of McMedHacks 2023. Today we have the pleasure to have Dr. James Tsui as our speaker to give us a talk. I will start my usual introduction in terms of where we are in the week. And here we go. And just 1 second. James, do you see my speaker notes?
I do see it's blank.
Well, okay. You know what? Because I have your introduction here, so I will just do the normal yeah, like this. Okay, so today James will talk to us about his research on deep learning based, deep learning based auto-segmentation of organ at risk in cranial spinal irradiation of pediatric patients. So here we go. Again, if you have any questions, feel free to email us at medpacks2021@gmail.com. Again, we are going into the second phase of the summer school. For those of you that have completed the phase 1 from week 1 to week 4, we have gone through the fundamentals in deep learning applications, mostly in medical image analysis up to week 4. And starting last week, we started topics on self-supervision, and this week we will start in natural language processing. So the second phase, the goal of this is to get into more of the state-of-the-art methodologies in the medical AI world. And all of the certificates will be handled at the end of everything in August. And we will specify on the attendance calculation more tomorrow at the workshop session. And this is the attendance will be counted from the Zoom attendance, and there is a minimum of 30 minutes of login time for an attendance to be counted. And again, everything has been posted on the Gumroad platform. If you're not able to access that, we have also provided everything on Google Drive. Gumroad is an online course platform where you can take a look at all of the online materials for preparation, as well as the live materials that we have going on the weekends here. So again, from our timeline, we're the third last week of the entire program. This week, tomorrow we'll go into an LP, and you can go on our website to take a look at the program. Today we have Dr. James Tsui, and tomorrow we'll have Dr. Persa Barzadeh to give a live session on the coding workshop on NLP. And this week, we have the pleasure to have 2 mentors again. We have Sami as a returning mentor, as well as Elaine. So if you are in the audience, feel free to unmute to say hi, or be engaged in the chat to answer any questions, and as well as the Q&A period at the end. We will, as usual, hold the tutorial session during the week, and my colleague Hossein will be in touch with you for that. Great. If you don't mind, I will introduce Dr. James Tsui here. Dr. James Tsui, he will go through his research on auto-segmentation of organs at risk in craniospinal irradiation of pediatric patients. Just in short, he has many degrees. He has done a bachelor's degree in electrical engineering at Concordia, and he has a main interest in the human mind. Later led him to pursue a PhD in computational neuroscience at the Montreal Neurological Institute in McGill. And he's been, and his work entailed building descriptive and predictive mathematical models to help explain phenomena underlying conscious perception of motion. And it was while working in the hospital setting during his graduate studies that exposed him to medicine, which led him to complete his medical doctor and MD degree in 2015, as well as the residency training program in radiation oncology in 2020. at McGill University. And after that, he has been a practicing physician at the Royal Victoria Hospital and was appointed assistant professor in clinical oncology at McGill. And on top of that, he has also recently completed a brachytherapy fellowship at the Brigham and Women's Hospital at Harvard, Boston. He has also finished a professional master's degree in artificial intelligence at MILA at University of Montreal. Currently, he's working on a lot of the applications of deep learning in medical imaging and in a very clinical setting as well. James, if I missed anything, please feel free to add on to that.
No, you got it.
Yeah, great. I think that's it. It's a big pleasure to get to know James over the years and to work with him as well. It's truly a pleasure to see your work being applied to as both a clinician as well as a computer scientist. So please go ahead. Thank you so much, James.
Thank you. Thank you for the introduction. Thank you for the kind introduction, Eugene. And thank you, Sharon, also for connecting us for this session. And thank you all of the attendees. I know that it's Saturday morning for some, night for others. And thank you for your interest being here to listen to me. I glanced through the YouTube videos that's already uploaded, and I must say I'm very pleasantly surprised and happy about all of the materials that's been covered. Lots of AI stuff, lots of deep learning stuff. Today, my talk is mostly going to be the application, not so much about reinventing the wheel or proposing new, cutting edge technology, but more focus on the clinical application. There's quite a lot of studies in AI/medicine, deep learning cross oncology. A lot of literature been published, not so much in the application, however, in the sense that, our day-to-day activities, we're slowly seeing AI and ML take more and more precedence and more space. But in terms of the balance of research output versus the application, I think there's still a lot more room for the clinical side to very much apply what's already very much studied and out there in our everyday clinical practice. Today, my talk is really just an example of how we can leverage a very simple deep learning algorithm that already exists into the clinical practice. And I also looked at the number of people who are sign up for these courses, and it's comes from a variety of background, a lot of biomedical engineering, medical physics, computer science, some from the neuroscience, radiation oncology side, medicine and medical physics, but to make sure that everybody have an appreciation of what I'm talking about, I'll also spend a few moments to talk about the actual medicine, why we're treating what we're treating, to make sure that everybody has an appreciation of why we're engaging in this kind of research. So today my talk is basically a deep learning auto-based auto segmentation of organs at risk. And let me just get to the right screen. And the motivation really started with a discussion between the Children's Oncology Group and McGill Medical Physics Unit Department. So Children Oncology Group, they run a lot of clinical trials all around the world. They're the largest group that does so. And most of these, or rather all of the participating centers, when they enroll patients in these clinical trials, they have to submit radiation plans for review, central review, in which organs at risk of receiving radiation, not the target, are delineated. Now, to make sure that everything is compliant to protocol and QA standard, quality assurance process is done, and it's quite time consuming. So basically the COG was looking for a solution to quickly verify whether the organs are properly delineated. And this led to the collaboration between St. Jude Children's Hospital and McGill University. So data were provided from St. Jude, and basically the deep learning expertise was provided from McGill. Now, here's the outline of my presentation. First, I'm going to explain to you what radiation therapy is. Then I'm going to talk to you about cranial spinal irradiation, or in short, CSI. I'll talk about the different auto-segmentation. I believe some of the speakers have already touched upon that in the previous lectures. Finally, I'll talk about the pipeline. So what is radiation therapy? So in case you don't know, half of Canadians, half of North American actually will have cancer in their lifetime. So I need two people one of them will be afflicted with cancer in their lifetime. A quarter of Canadians will die of cancer in their lifetime. And the treatment of cancer is really very much divided into three main categories: surgery, chemotherapy, and radiation therapy. Surgery is straightforward. It is what it is. You do a surgical resection of the tumor. Chemotherapy is when you give chemotherapy, systemic therapy, drugs, immunotherapy. Radiation therapy is one that may not be as known as the other two methods in the general public. Essentially, we employ radiation beams, so ionizing radiation beams, and we target it to the tumor to induces DNA damages such that the cells will no longer be able to replicate, or when they undergo cellular division, they die. The radiation therapy workflow is quite long and complex. So first of all, you have to see the medical doctor. Treatment decision will be decided with the patient. The patient will have to go through image simulation to acquire treatment planning scan. Then we have to draw the contour, plan the treatment process. It goes through a number of series of plan approval and quality assurance. Finally, radiotherapy is delivered and we follow the patient. It's a time-consuming process. Sometimes we don't have that luxury to wait too long, especially if a cancer is growing. However, the workflow is quite linear, especially in the planning phase. So you scan, you post-process the images, your contour, you treat the patient, all of which are serial. They're not parallelly done. And so any thing that you can do to minimize the time that you spend in each one of these processes will help in terms of the waiting time. During the time between consultation and treatment time, the patient is just at home waiting. So in addition to the quality assurance process with auto segmentation, we could actually help with the contouring part and minimize, at least shorten the waiting time. So what is cranial spinal irradiation? Cranial spinal irradiation is when we give irradiation to the whole CNS, so the cranial nervous system, the brain, as well as the spinal cord. This is usually done in cancer that has a tendency of spreading via the cerebral spinal fluid, and that's why all of this becomes our target. Usually, the pathology that are afflicted are pediatric disease. The challenge is that these are the targets, so the brain, the whole spinal cord, and the cauda equina, and these are the organs that you want to avoid. And these are only some of the organs. There are many other organs that you want to avoid. And it's important to note that in pediatric, their organs are a lot more radiosensitive than adults. For example, the vertebral body, something that in the adults population, we don't really care so much because it's already all formed, adult and matured. But the kid is growing, and there are a lot of growing bone cells, if you will, stem cells, that if you radiate them, well, they'll stop. They'll stop functioning. The child will stop growing. The problem is when you don't radiate the whole vertebral body homogeneously, you just radiate the hotspot a little bit more anterior or posterior. What happens is that the vertebral body grows crooked. So essentially, you can induce scoliosis or kyphosis on a growing child. So making sure that you're contouring the vertebral body becomes a very critical thing in the radiation of a child. The other challenge for cranial spinal radiation is you're not acquiring only one organ, you're acquiring the whole body. So you have anywhere from 400 to 700 slices, depending on the age of the child. The slice thickness are quite small. Delineating organs have a lot of intra-observer variability. And we know that deviation from the QA protocol, the quality assurance protocol, compromises outcome. So slice by slice QA quality assurance takes a lot of time. And again, that's one of the motivation why the project started in the first place. What are the different methods of auto segmentation? So there's many. Manual segmentation, it's straightforward. Atlas-based segmentation I'll talk to you about, and some deep learning auto segmentation. There are commercials and in-house. I should know that as of now, there are many commercial segmentation tool. When I started the project, there were not many. But the commercial segmentation tools, they're all FDA approved, Canada Health approved, but none of them were validated in the pediatric population. In fact, they don't have FDA approval to do the children's auto segmentation. And the other method that I'm going to propose today, it's in-house. Again, it's an example of how you can leverage what's already been done in the literature, but in a clinical setting. So Atlas-based segmentation, what is it? So basically, you need to have a library of a lot of the similar structure. For example, here we're contouring the heart. You have to have a database of a lot of hearts. You choose some that resembles the heart that you currently, the target input image looks like. And then you look at the corresponding segmentation mask, which is the mask of the heart. You perform a registration, so a deformable registration to see what needs to be deformed to look like the current heart that you have for target. And you apply the same transformation on the contour. Usually what works well, but when it doesn't, it can fail spectacularly. These are some example of how Atlas-based segmentation doesn't work too well. For example, this is the kidney, and this is the mask. You can see that it doesn't capture the actual kidney, how it looks like. This is the vertebral bodies, and essentially it misses it. Deep learning based segmentation usually is composed of 2 or 3 components. The first component is called the encoder. It takes as input image, goes through a series of convolutional neural network, and essentially pulls the bottleneck layer here. This is a vector of a bunch of numbers, depending on how many features you want in the deep learning embedding. But essentially, this contains all of the information that you need to recover this image. And you feed all of that into a decoder, which is the inverse of a convolutional neural network, that regenerates a segmentation mask. Here you have cars, you have street, and you have building. One that's very, very popular, it's called a unit, proposed in 2015 by Ron Berger. Till date, it's been cited 64,000 times. Every time I check on Google citation, it grows up by hundreds. It was a very popular model. It won the ISBI challenge in 2015. It was originally designed to segment and track moving cells in time-lapse video sequences. But it has since been shown to be very effective in doing auto segmentation in medical images. Because it's been cited so often, and used sold widely. In fact, pretty much all of the commercial auto segmentation tools is based on a unit variant. I figure it would be important to spend a little bit of time to explain what the unit is, unless you tell me that some other people have already explained it previously.
I'm sure people have seen it, but go ahead. I mean,
Okay.
There's no harm.
Okay. Yeah, I'm doing it because this is like the foundation, if you will, of auto segmentation as of like today.
Yeah, no, yeah, absolutely. Go ahead.
Yeah. So the input image goes through a bunch of convolutional block. Here it's just one channel input, splits to 64 channel. In other words, 64 features at the entry level, and as you're going through the convolutional block, you get more and more features. So each feature extracted by a convolutional filter. These are low-level stuff are usually like edges and blobs that looks like this. Off note, this is a deep learning algorithm or implementation. Deep learning by definition means that you don't define what the filters look like. The unit automatically, or the convolutional network automatically figure out what are the best low-level features and high-level features that would be needed to accomplish the goal. Now, in my prior life before medicine, I did a PhD in computational neuroscience. My job was to record single neuronal responses as the macaque, the monkey, is looking at the visual field. And these V1 cells, the primary cortex cell, they respond to certain visual stimuli. If you show them a visual stimuli that corresponds to what the V1 cell is quote unquote programmed to do, it would fire a lot of neuronal response. So when you look at these cells that fire the most neuronal response and you correlate it with the visual feature, turns out what happens is that these are the kind of images that these primary visual cortex neurons are most sensitive to. And you can see the similarity between this and that. These are original macaque primary visual cortex kernel, and these are the filters or kernels or windows, however you want to use it, call it, in a deep learning convolutional neural network that was learned automatically. It's as if the neural net, the deep learning training was able to replicate what the natural selection have done in nature, and how our brain are formed. So I thought that was an interesting side point for you to understand the power of a deep learning neural network. Okay, going back to the unit, basically these low-level features are then passed into the second layer of convolutional neural network. The resolution size drops down, or rather the size of the input image drops down by a factor of 2, where the channels increases by a factor of 2. So you have more and more features integrating information from more distant pixels in the image. You continue this process. You go to the bottleneck layer, which contains a rich deep learning embedding or data representation of the input image. Then you feed it back into the decoder. There's also a skip connection. For 2 reasons. Originally was thought that by doing so, by feeding the skip connection, it gives spatial information so that the decoder can have more contextual information. There's some who believes that it actually helps with the training, like a ResNet or a DenseNet. Basically, it gives the skip connection the ability to mitigate a little bit the idea of vanishing gradient. If you have a very deep learning neural network, what happens is if you keep going deeper and deeper and deeper, and if you start taking the derivative differentiation during the learning process, your gradient can become small. And when it hits 0, then basically the whole neural network collapses and stops learning. So the skip connection helps with this the training process. So I integrated basically all of the deep learning implementation that I tried uses a different variant of unit. Limbus AI is probably a variant of unit, and then unit I'll explain to you. Well, I'll explain to every single one of these implementations in a little bit more detail. So which one will do best? Limbus AI, commercial product. It's around 30K a year. It's fully automated. Basically you put the patient on a CT simulation, you get the limbus contours, and you get the treatment planning. The treatment planning get all of the contours. It was tested on 1.6, but I think we also tested on 1.7 and I believe 1.8. I'm not sure. Sharon, you can maybe correct me on that. I forgot what was the latest version we corrected on. But here's some pros and cons. Seamless integration into the clinical workflow. There's no training, just plug and play. The cons, however, is no training. Essentially, what that means is that you're provided the sets of contours. There's a lot, but there are still some that you need, and they're not, they're not included. It's not so easy to plug and play. You still have to do some IT setups. Some structures are not included in the package. The other deep learning implementation, the NN unit, proposed in 2018. This paper was written in 2020. It's short for no new unit. The idea is that UNet is a very, very powerful, large capacity neural net that's able to do quite a lot of the work. In recent years, a lot of people has been looking at different ways of proposing different auto segmentation, deep learning implementations and algorithms and models. Each one of them a little bit more powerful, more capacity, more complex. But the reality is you probably don't need all of that. What you really need to do is to do the pre-processing properly and the post-processing properly. The pre and post-processing and also the choice of your parameters and hyperparameters, it's an art in itself. But there are a systematic way that you could approach that to really get it done properly. So the no new unit is essentially a super large package that offers the self-configuring capability. So essentially what it does is you just feed in the data and the NN unit will analyze the data image signature and distribution signature and choose the right model architecture and the right parameter choices to achieve the whatever you want to achieve. Here are some examples of how they use the NN unit as is. Just download it off GitHub, plug and play. And they participated in a number of international segmentation challenges. The blue dots are the dice scores of all the other models, the competitors, for the specific organ that they're trying to contour. Here's the liver, pancreas, right adrenal gland, aorta, pancreatic cancer, liver vessels, so forth and so on. Dice score on the y-axis, the red dot is their dice score of the NN unit. You can see that it's always ranked in the first, top 1 percentile, if you will, just to show the power of the NN unit. Pros, out of the box, ready to use, just pip install, run a command line, it's free. That's it. Cons, it needs a lot of GPU memory and a lot. So I like basically I couldn't I ran all my training segmentation on Compute Can, now called Digital Alliance. The author says you need at least 10 gig, but the reality is you need at least 40 gig or more. It's very long to train. For some reason, like they say, like on their paper, it takes like 48 hours, 24 hours. Some people say the same, but the majority of the people at Hook takes a whole good week to run training because it trains for 1,000 epochs using a 5 cross validation scheme. So basically, it trains for 5,000 epochs. You can think of it like that. Took over a week to train 115 patients. Inference time is also expensive. So for 29 patients, and you need 65 gig CPU, took 71 minutes to get it done. Compute Canada also tells you your CO2 emission calculated for inference was 0.14 gram, which is enough for to drive 1.85 kilometer using an electric vehicle. It's quite impressive. The other deep implementation is YOLO and all the other variants that I'll talk to you about. So what is YOLO? YOLO stands for you only look once. It's very powerful algorithm. I think it was Facebook or Google. I'm not sure exactly where the original paper originated from, which group. Essentially, you have an image and you go through a bunch of convolutional neural network and you cover a bounding box to train like data detection. Here is basically an example of bounding box showing it was 64% accuracy that this is a person, this is a dog, and this is a horse. And it's so powerful and easy to use that a lot of people have been develop a variant to the computer vision paper release. Yes, somebody said the paper by Redmond. Exactly, it was proposed by Redmond, but 2015. I'm just reading a chat right now. It was Redmond who proposed it, but I think he was working at Facebook or Google. I'm not sure. And then a bunch of other examples. People have employed it. Now we're up to YOLO V9, I think the latest one. People have been employing it for object detection. The NN unit also does something similar, especially for large data set. They use something called a unit cascade, where they use unit to basically downsize the resolution, feed it to the unit, and then look at the bounding box, and then upsize the resolution, and use that to bounding box to again recover like where it is in the image that you're interested in doing the auto segmentation, and then goes through the unit again and spits out the auto segmented contour. You can imagine that this is like very, very time consuming, and it still employs quite a lot of memory because you're still feeding the 3D scans. So digital reconstructed radiograph is a technique that we radiation oncology used to employ quite a bit in the past, especially prior to the advent of 3D CRT, which is basically a 3D modulated radiation therapy. Back in the old days, I'm talking like 20, 30 years ago, this is how radiation is done. You know where the lesion is located. Like, for example, lymphoma is like in the thorax, in mediastinum. You take an X-ray and you're like, oh, I think this is where the lesion is located. And then like you take a large beam and you put lead to block like the stuff that you kind of wanna avoid. So namely the lung, the throat, whatnot. And then you just radiate like that anterior posterior, and you flip the patient around and you do posterior anterior. So the whole like anterior posterior field gets blasted with radiation. Later on, technology evolved and we became better at employing images. But the old thought of like, acquiring a X-ray of a patient on treatment position in one plane still persisted. So instead of having X-ray anymore, we have CT scans. But to regenerate the X-ray scans, we do the digital reconstructed radiograph. Puts very simply, it's essentially you're summing, you're adding all the pixels along a dimension to collapse a 3D image to a 2D image. And you could do something a little bit more fancy too. You could clip the Hounsfield unit. So on a CT scan, Hounsfield unit is the intensity, the pixel intensity, and it has a physical correlate. It actually means the density of the material. And that's important for radiation therapy because the more density you have, so bone, for example, the more radiation you absorb. And because it absorbs so much radiation, it blocks the photons from hitting the film. So that's why like it looks like that on the film if you're looking at the bone window. But when you're doing the summation along the axis, you could clip a bunch of values to 0. For example, if I don't care too much about the bone, I care more about the soft tissue, which has a Hounsfield unit that sits around like -50 to 200, for example. I can clip anything below and everything above, and I could have like a more soft tissue window. In this case, is more a lung window. So if I do the DRR on octagonal scans, so like coronal and a sagittal, essentially I could train a YOLO to basically detect where the lung is located, for example. And using just these two bounding boxes that YOLO gives me in terms of the bounding boxes, the boundary boxes, I could just recover very easily the 3D volume from an octagonal scan. Instead of feeding a whole body CT volume to different unit for the unit to tell me where the bounding boxes is. Now all I have to do is just feed in 2 images. Okay, so some people in the chat say, can you elaborate more on how you relate NN unit and YOLO here? NN unit is for semantic segmentation, YOLO is for detection. So I'm explaining now. So essentially YOLO is for detection. Yes, it gives you a bounding box. With the boundary box, then I could just find exactly where it corresponds to the whole 3D CT volume and just basically use that and feed it into a organ specific unit segmentation. Does that answer your question, Hazrat? Basically, I'm splitting it into like a 2-step process. Yes, thanks. Okay, good. So it's a little trick leveraging what's out there to basically cheat my way out of instead of feeding a whole body 3D volume of 700 slices, if I only want to contour the eye, for example, all I really need is like 30 slices around here instead of 700. So I'm using YOLO to find where the eye is located. Vanilla unit with a twist. So then I fed the volume into organ-specific unit. Now, on the NN unit is like you're doing multi-class segmentation, and you're interested in all the organs of the body. So your Hounsfield unit range is super large because you want to account for all of that. And in a unit, they look at the NN unit. They do some normalization. They clip the values to like the 5th percentile to the 99.5 percentile within the mask, if I'm not mistaken, if memory serves me well. But if you're doing organ-specific stuff, like you don't need that big range. What you're really interested in is pretty much what's inside a mask and maybe like a 2mm rim around. So I explored like different windowing scheme. If I use like a 10 to 90th percentile of only the pixel value inside a mask, this is the image I get. If I only care about like the rim information, this is the kind of image I get. If I use a 10 to 90th percentile of the pixels inside and outside the rim, this is what I get. And if I use the minimum 10 percentile either inside the volume or the rim, and I clip the value to maximum 90th percentile, it should be inside and outside, and around the rim, this is the image I get. You can appreciate how like it's easier to appreciate the kidney on this image than this, and a vertebral body on this image than that. So pros: more control, less training data needed with proper augmentation, less memory, less GPU, fun if you like the art of building and training deep models, easy to learn. The con is it's not that easy to, it's easy to lose control. If you don't know what you're doing, like it may not train, require a bit of domain expertise, a lot more pre-processing required, not so fun if you don't like the art. I should also add the other pros is that once I got the inference model, once I got the model trained, I was able to infer the auto segmentation mask using my my laptop that I use for Netflix. So I was able to do it within a minute per patient. So there's another pro. It's a lot easier in terms of inference, and you don't need like powerful GPUs. The other twist that I did is I just tried to add some attention gates. There's been different literature that shows that attention unit is a little bit more powerful. Zero work done, not many more parameters. It's still based on local feature, not really a true transformer, so to speak. It was just looking at the channels as opposed to looking at all of the pixels. Can you share how you did these steps? I'm not sure what you mean by share these steps, Reza.
I think you might have meant the windowing, the percentage. If you go back.
Like this?
Oh, sorry, not windowing. Yeah, this.
Yeah, yeah, it's essentially windowing. So again, Hounsfield unit minus 1000 is like air. 500 to like 500 and above is like bone, like thousands, 2000s like implants. So the idea is that the code and the article. Well, I'll get back to you actually after, because I'm not sure what you meant by share these steps. You could get in touch with me after. Okay, so the 2D unit, 2.5D unit is the next thing I want to talk about. The unit uses one channel, but the reality is you could use 3 channels. You could use the center channel that you want to do the contour. So this is a kidney, but at the edge of disappearing. So just one slice above, it's gone, and one slice below, it's again kidney. But if I just feed you this slice, even if you feed it to a radiologist who will say, oh, it looks like the kidney, but hey, maybe it could be the bowel, because sometimes the bowel loop comes and go. the only way that you can know is to just scroll up and scroll down to see whether or not it's the real kidney. So basically, I use a 2.5D. There's another implementation also called 2.5D, and not to be confused. It's not the one where you feed the octagonal 3D images and you recover the 3D volume. At the same time, there's another clinical group that use the name 2.5D. Essentially, just feeds in the superior slice and the inferior slice inside the unit and gets the auto segmentation out. The pros is it gives more contextual information, very little work added, doesn't add a lot of complexity, same as vanilla unit. Training becomes a little bit more dicey, especially if like the superior or the inferior slice has empty data. So for example, the brain, this is the validation loss and this is the training loss, and you see at the end, like you have these spikes. Okay, pipeline. I'm just reading the chat about yes, coupling between YOLO and UNIT is a nice cheat to basically detect first and then do this auto segmentation. I should also mention that this idea is not new. It's actually called the panoptic segmentation. I think it's called panoptic segmentation, where people just use a YOLO to do the segmentation process. It can be done. You don't even have to do a two-step process. The whole thing is end-to-end. So the pipeline, identify the patients, data set, split training and validation, contouring, the manual contours are already done by Sinjud. All of the patients are anonymized, and the whole thing is exported into a Python environment. For Limbus AI, we don't need to. Essentially, we can just get it directly. Because there's no training involved. In the Python environment, you need to do some pre-processing, label extraction for YOLO first, and then you apply the different units and you do the post-processing. And you could also train the NN unit. We combine everything together. NN unit also has post-processing done within. You compare the metric and then you look at the contours. Pre-processing, I started with 100. I think I'm just gonna fly by these things to basically make room for the results and also the discussion. These are all the organs at risk that were involved. Extracted the YOLO bounding boxes. This is how it looks like for, I think this is esophagus, left kidney, right kidney, vertebral body. I did some cleanup, so I looked at the distribution and found some like outliers. Usually it's because the laterality was not well defined, left and right. Sometimes because it's not well contoured. I clean those up. The YOLO Hounsfield unit that I told you about, the clipping window, these are the one to get the lung window, the soft tissue, the bone. YOLO expect a RBG channel. So essentially I just combine all three to get this. And it actually looks pretty nice, actually. This in itself gives me all of the information. Like as a visual observer, this alone, I could tell you all of the organs where they're located. This is an example of how it can identify the brain, the kidney, the CTV spine, the orbit. I'm just gonna skip through this. These are just the amount of patients that I have. And then unit. I'm just going to go directly to the post-processing and the metric. The post-processing, basically, I use a 3D 26 neighborhood connected components. It's just to make sure that I get like one single volume. Everything that's not connected gets discarded. I use a dissimilarity coefficient to look at the overlaps metric. To answer your question, Reza, it's not a PET CT. It's just when I combine all the three different Hounsfield unit windowing, it looks like what you saw there. Okay, so these are the results. Looking at the table can get you dizzy, so I'm going to show you some bar graph. First is NN unit, then Limbus, then the three variant of unit. The Limbus doesn't do too well on CTV spine, can't do the OTVVB, the vertebral body, because it wasn't trained to do. For some reason doesn't do well in a lot of the other structures. But again, it was trained on adult population, validated for adult population. If anyone works at Limbus AI, don't sue me. Like I'm telling you that it wasn't done for the purpose of pediatric patients. And the reason why I'm using that is because I'm using it just to see like how it does in terms of in the pediatric population. And then UNET doesn't do too well with the eye structures and the brain structures for some reasons. And I suspect it has to do with the augmentation of the algorithm because they do the mirroring, and all the other in-house built kind of it's on par. So this is just the example of how the contour looks like. Limbus AI doesn't, it has a tendency of dropping slices. Again, I'm mentioning that it's not validated for pediatric. This is how the esophagus look like. Red is my esophagus. This is the reference. You could argue that the reference is actually not well drawn, because if I were to contour it, I would also include a little bit more medially, and then UNET included the medial portion, but like drops the lateral portion. 2.5D UNET is probably the one that's closest to how I would draw the esophagus. The kidney, and then UNET does pretty well. Limbus AI has a tendency of like excluding the hilum. It's not wrong. It's okay. It's just like when I draw it, I have a tendency of including the hilum because it doesn't really change much in terms of, I want to protect the hilum essentially. And this is how 2.5D UNET looks like in attention UNET. Limbus AI, for some reason, has a tendency of dropping the kidney sometimes on different slices. The reference was not well drawn, but the auto segmentation's deep learning algorithm actually does it better. And this is important here. You see this little guy right here, this sliver, anatomically speaking, this is the end of the diaphragm. It's a muscle, and it's okay not to include it. And if you are if you like steak, this is the hanger steak. Which is basically the diaphragm of the cow. So on the coronal slice, this is how Limbus AI looks like. It drops a few slices. Eye structures, the eye, and then UNET has a tendency of not knowing if it's left eye or right eye. These are, some other optic structures. The optic chiasm is always a tough one to draw. Dice score, by definition, penalizes small structures, so this chiasm is never a very high-performance structure. So in summary, like we tried different deep learning auto segmentation. We used a commercial. Still need to, you could use the Limbus AI to do your auto segmentation for pediatric. It's just that you have to bear in mind that it's not going to be superb for certain structures, and before putting the patient on treatment, you have to make sure that you fix those. And then in units is very much easy. It's out of the box, but it takes a lot of resources. Custom built is one very simple way for you to implement what you need in the clinic. And the implication is large. It can improve workflow, reduce inter-observer variability, quality assurance, and can certainly add value to a strain resource setting. Portion of this work was presented already at ESTRO, the European Radiation Oncology Conference. And these are all of the people who are involved in the project. I just want to express my gratitude, actually, especially for Sharon Anger. She was and also Maria. Those two are the one who really connected me with St. Jude Children's Hospital and allowed me to work on this awesome project. So thank you very much for your attention. I will continue sharing screen. But yes, I'm ready to take some questions. Marcia, unless Eugene, if you want to add something first.
Oh, no, I just wanted to say thank you for your presentation, and we can start the discussion. Is there a time that you have to leave so I can be more controlled in the
Yeah, 11:35.
Okay,
Yeah,
so we'll have like a 15-minute
yeah.
question. Thank you for also, answering some of the questions along the way. And let's see. Uh, well, what was the last one that you answered? Did you answer
I think Marcia Han said, "Is your research being applied, or do you need to go through certification approval?" Okay, so here's the thing: when industry wants to sell a product, it has to be FDA approved, it has to be Canada Health approved to be used in clinic, and it has to go through a variety of certification processes. When the clinician, and when the group in the hospital decide to use AI, lots of caveats. You want to make sure that you use something that you could visually check. For example, auto contouring. When you get the auto contours, you have to go through a series of quality control. You have to look at it. It's the same thing as if I train a resident to do my contour. I will never accept the contour a resident gives me and put it to treatment unless I see it first and I check it and I make sure everything is compliant and everything is good. So in that sense, when there's something that you can easily check, then I would use it in clinic. It's no different than when you do a script in the clinic to make your workflow faster, or you automate the processes that makes it faster. I will never use, and I will stress never, 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 never use a tool that was developed in-house for risk stratification of patients. For example, which patient you would not treat, which patient you will treat. If I do that, if I rely on a black box from a score given by a deep learning model that was never externally validated, and I use that as my clinical decision making, I could guarantee you that I will get sued in the future should things goes wrong. No clinician will ever use those kind of tools that were never validated to make clinical decision. But there are tools that are clinically validated. For example, multimodal AI was something that was proposed, I think, last year in the risk stratification of prostate patient that was validated on phase 3 multi-institutional trials. Collected by the RTOG, and it was validated on a data set of thousands and thousands and thousands of patients. That's company validated, FDA approved, now recognized by the NCCN guidelines. NCCN is basically the National Cancer, I forgot exactly the full acronym, recognized by NCCN as a clinical tool that you can use. So I hope that answers your question, Marcia. Sammy say very interesting. There's also other techniques of segmentation, such as thresholding, edge space, active contour models. Again, I don't reinvent the wheel. You said it right. There's so many techniques for segmentation, so many stuff that's already out there. Use the simplest, apply it, check if it works. At the end of the day, these are not like clinically validated stuff, so you still need to check it. Limbus AI or other RayStation, RaySearch, Variant, and Lecta, they all have their own flavor of auto segmentation. They all use like similar stuff or maybe some new techniques. Like I would say like use their product first, but only like develop something when it doesn't meet your need. And again, a very stringent quality process is required. And then Hamid said the AI implementation in medicine only when the accuracy more than 90%. What about this myth? Can you elaborate this? I don't know about the accuracy more than 90% thing. But the thing is, if you do AI implementation, again, there's two path, like I told you, some stuff that you can verify very easily, like contouring. These things, even if the accuracy is not like 90, if it's not 80 or it's not 70, it doesn't matter, because there's always like several human quality insurance steps that are involved in making sure that at the end of the day your treatment is safe. You just want to make sure that the reason why we do all that is to speed up the process, the workflow, the inter-observer variability, to reduce all those. But there's always a human check, and most of that is for workflow processes. In terms of decision making, I will never use something that's not FDA approved or validated, because you don't know what's happening, like how the algorithm is done, and what exactly what features they're looking for. Now the whole idea of, like, how accurate you are, let's go back a step and see how currently it's done. Currently, when I make a clinical decision, for example, prostate cancer, maybe in the future you'll have the Cipher score genomic and all that. We're using that in the clinic, sometimes under the clinical trials. If not, the genomic, the Cipher, I think, is like $5,000. MMAI is probably like something like $3,000 per patient. So the most simple way, clinical way of stratifying patient on prostate cancer, for example, is your finger. You look whether or not you feel a bump, your PSA, look how high it is, and your Gleason score, which is the pathology. Understanding that in the trials, there's a big variety. It's not like, oh, you have like 9.9 PSA, so you're low risk. Oh, you're 10.1 PSA, so you're intermediate risk. So therefore, your treatment strategy changes. The reality is patient sits on a normally distributed Gaussian curve. So even if like the median is such that we use that to decide like low risk, intermediate, and high risk, but the reality is, even if you have like all of the criteria is to be at low risk, you can be intermediate risk, and we should treat you a little bit more aggressively. So even the clinical thing, the accuracy is in stratified in the patient is not great. It's you still have to supplement with a lot of clinical decisions. So okay, I hope that answers your question. It's a very long elaboration. Guang Zhang said, "Thank you for the great presentation. I wonder if ECG could be analyzed as other medical images like MRI, classify with and without heart failure based on ECG images. If yes, which models you?" Okay, so ECG, electrocardiograph. I just want to make sure because ECG, like, you have a graph, but the reality is the graph is like the graphical representation of a time signal. So if you were to use the ECG data to do some sort of classification, which is already done, by the way. When you take an ECG, usually like there's a computer recommended pathology that's going on. I would go straight to the source and use the time signal to do the analysis, not the images. Because if you use the images, you could, but then like you're taking you have to go through the step of getting the data representation of an image, which is a representation of a time signal. So I would go straight to the time signal and time series and use that to do your analysis. If you have access to it, of course. Hemant Jamil said, nothing perfect. So what about the validation, accuracy, and precision to implement auto implementation and treatment planning? So by treatment planning, there are many works that's being done. There are works that look at the images of the patient and kind of predicts like what would be the dose distribution, the ideal dose distribution. Recently there's actually a nice paper, I forgot what group, but they showed that it was a prostate end-to-end. They put the patient MRI images, and there was absolutely no human intervention, and at the end of the day you have a treatment planning done already. And that's pretty cool. I do not know about the accuracy of such, but it was a proof of concept that it can work. How can we contact you? Fine. Here, let me just get your, I don't know if here, my email. I mean, you could easily find out my information online anyway, like LinkedIn, email, this would work. And I work at the Royal Victoria Hospital, McGill University. Sami Bahig is to answer Hamid question. Hamid Jamal, the double or cross check is the near miss instinct picking idea. So what about the model implement after perfect validation and FDA approval? What tool may be used as double? Oh, he's still human. At the end of the day, every plan that goes out, every plan that gets treated, I sign it. And should anything happen to the patient, I'm responsible. So you can rest assured that I will always make sure that I check all my plan, regardless of whether it was a human, a model, a resident, the dosimetrist who did it. I check. And even before it gets to me, there are multiple different QAs that are done. Different automated methods are being implemented right now. I sit in a committee right now that we're looking at different ways of automating the check. But at the end of the day, I am responsible for the patient. So for sure, I will always check before. What else? Thank you so much for the advice. When Ganjal, Reza said, thank you for the great presentation. Cool. Any other
Thanks, James.
questions?
Yeah, Shireen has been raising her hand.
Oh,
I can lower my hand now. So thank you so much, James, for this very exciting and inspiring presentation. I have a problem myself of all the AI tools that are coming, that we have some of them at the hospitals that are black box. So black box in a hospital environment.
yeah.
As a clinician, how can you, even though they are FDA approved and have gone through all the regulatory approvals, can you really trust them, you know, if you don't know what's going on?
Okay, put it this way. I will only trust them. I will not rely solely on, and I'll give you some example. I will never rely solely on them unless it was proven in a large multi-institutional phase 3 trials. For example, like let's shift gear and talk genomic, let's say. You know, whether or not you choose to put a patient on tamoxifen is given by your Oncotype DX. Oncotype DX is essentially they look at a bunch of genes and then tell you, oh, this patient is at risk of recurrence at how many, like, you know, percentage and how many years. Therefore, you should put this patient on this treatment. Now, I use that because this is now the standard of care. Everybody uses it. And I use it because sometimes it's because I really don't know whether or not to put the patient on like this treatment versus that, because, you know, I feel like, oh, maybe like both treatment works, but let me just look at Oncotype DX. Oh, okay, so it's that. So I'll put you in that category. But again, Oncotype DX is very much validated, so you would not like when Oncotype DX gives you something, you have Taylor X trial that tells you like what to do. MMAI is the same thing. You know, people are now using the Cipher score to help them with the clinical decision. Sometimes I see a prostate patient, I really don't know if I should put them on hormone or not, because, you know, they're elderly, they have like, you know, cardiac problems. You know, there's other side effects. I can make you a little bit more, you know, your cognitive side effect is not benign. I really don't know if I should go one way or another. If I have a score in front of me, sometimes it can tip me one way or another. And right now the Cipher is being studied, so I like, we don't have the clinical standard of care so yet to say, oh, your Decipher is this for intermediate risk cancer, so you have to use this kind of hormone. It's still being studied, right? So I could use that to guide my clinical judgment, but I won't use it to say, okay, this is absolutely what you're going to do. If one day there's a big trial that has established a standard of care, then I have no choice but to use that black box AI to choose my treatment decision. A lot of them right now, even though they're FDA approved, it only helps to make a clinical judgment. It doesn't make me, like, you know, confined to actually treating the patient based on what the AI is telling me. Yeah, I hope that answers your question.
Yes, indeed. Thank you.
Thank
Very
you, Shireen,
welcome.
for your question. I mean, I have a lot more questions as well, but I think we can chat later since you have to leave at 1:35.
Okay.
Thank you so much, James.
Okay, thank
For the
you.
great presentation. I hope you enjoyed the Q&A period as well, and it was very, very engaging and really showed everyone kind of come back to earth a little bit from all of our, previous presentations where we talk about different techniques, but whereas this presentation is an entire pipeline that you apply to a very specific.
And that's
What-
because
what-
your command has been spawned onto
Okay.
different co-workers. And
Okay, I'm sorry about that. Please feel free to mute yourself during the presentation. Can you share some literature to review the current automation and external beam and brachytherapy through implanting? Yeah, James, maybe we can email back and forth afterwards on some of the literatures, and then I will share that with the rest of the participants.
Okay.
Great.
Have a nice weekend, James, and see you on Wednesday, I guess.
Yes, see you Wednesday.
Bye-bye.
Bye-bye.
Have a good evening. Not evening, afternoon. Bye.
Bye-bye.
Bye.